y'all talk about the application of vasopressors early in sepsis? Like how many liters are you going to give before maybe switching to vasopressors? I've heard something recently about its effect on the venous system versus just the arterial. Can you, and possibly doing pressors on non-ICU patients? So just that whole kind of topic.
So all of pressors, great. The question is the early use of pressors. Roughly how much fluid are we given before we're pulling the trigger on pressors? Is that right? Yep. Okay, I'm happy to take this. Or sure, go ahead. So if you asked me this a couple years ago, I would say that I'm probably giving someone at least 3 or 4 liters before I'm pulling the triggers on pressors, unless they're so sick I can't wait. We've all seen that person, their MAP's so low, even as you're bolusing in fluids wide open, you have to put them on pressors because their MAP's 45 and they're crumping on you. So I think everyone would agree that that person gets it started while you're volume resuscitating, not after, because you don't have time. For me now, it's increasingly 1 to 2 liters if I think that they're going to benefit from pressors. I'm a lot more stingy with fluids than I used to be. It's probably from listening to too many Europeans because Europe and Australia, at least theoretically, are a lot more stingy with their fluids, where they're advocating for like 250 and 500 ml boluses and continuous rechecks, as opposed to the American way of let's give them a gallon of salt water and see what they look like, because that's traditionally what we've done here. If you look at Promise and Arise and so forth, you actually end up seeing that the Europeans and Australians give roughly the same amount of fluids we do. But I still think that for me, I'm at least discussing the idea of vasopressors even after 1 or 2 liters if I think they're ultimately going to need it. Some of that is arrogance on my part of thinking that it's safer to put in a central line down in the emergency department than necessarily send them elsewhere. Some of that is, I think, if they're eventually going to need pressors, I'd rather start it early and titrate at a low dose than wait until they're super sick and then be behind the 8 ball.
So what about the thought that it's a whiff of pressors, you might as well have it off?
I think I've seen enough patients that need like a very small dose of pressors and have a very brisk response to it. But I think that's just clinical, just all more than like there's great literature behind that. Bruce, if you wouldn't mind using the microphone, because I'd love to have a veneer of actually being good by having Bruce Janiak.
Yeah, so straight microphone.
Oh. Yeah.
You gotta rest now, take a deep breath. What about the early use of ultrasound in those patients? If I'm going to give a liter and they're still hypotensive, and I look at their vena cava and it's just terrific, well, I think I'd pull the trigger earlier on the vasopressor.
Like it's plump?
It's plump. Okay. So yeah, it's already seemed to be maximally hydrated or adequately hydrated.
Agreed. And those folks that actually continue to have slit-like IVCs that are really low, then I still end up often giving them 3 or 4 liters before I necessarily pull the trigger on pressors. But the ones that are plump, I'm much more likely to have like 1 liter in an early decision.
So my take on that with the IVC is always keep in the back of your mind that the IVC is really a marker of the right ventricular and right atrial pressures, not necessarily the circulating blood volume, right? So you can have people who are hypovolemic with a big IVC. So you have to first understand that weakness and just making sure we all understand that weakness before we move forward. The next thing I do once I see that is I take a look at the heart, it's the LV. If the LV is big and hyperdynamic, and I don't think this patient has a pulmonary embolus, when I say big, I mean small and hyperdynamic, small end diastolic volumes, that's an LV that needs volume. It's an LV that needs volume. Now you have a real problem there because maybe that's a pulmonary hypertensive patient, maybe that's a tricuspid disease patient, pulmonic disease patient. They just can't get the fluid across. I think that you got to be really careful with loading that patient up with fluids because obviously they're already in RV failure. Loading more fluids isn't going to help that. So I do small volume. I'll do 500, see what their response is. And if there is no response, then I would consider something like an inopressor to start to see if I can improve my RV performance, to see if I can squeeze some blood across. I've used people who are just pure pulmonary hypertension, decompensated pulmonary hypertension, who were not on any of those pulmonary artery vasodilators. Maybe they are on them, I guess it doesn't really matter at the end of the day. Milrinone, I've had some success with. I don't use that very often, but that's the one time I've used it. We're going off into the weeds there a little bit, but Yeah, so I think early on, I think that to speak to your case, if you have a big IVC, I think that I'm going to be more likely to pull the trigger on pressors earlier.
Because that fits the cases you've discussed that are exceptions to the average patient. Right. And so you're more likely to be correct.
Right.
Just statistically.
Yeah, you got to look at it individually. We're not going to be able to give you a one size fits all. You got to look at your patient and make a decision on an individual basis.
I mean, the 22-year-old that's got great heart and lungs and suddenly became septic real quick, you're very unlikely to volume overload them with the same amount of fluids. Versus the 75-year-old with urosepsis and an EF of 20 at baseline is very easy to get into trouble with volume overloading those folks. And so you have to personalize it to where, a liter might be too much in that old person with CHF, but 4 or 5 liters might be incredibly reasonable with the hypovolemic young heart. So it varies a lot, but it used to be for me, I'd give a lot, and now it's a lot less before I'm doing pretty much what Rich is talking about.
To the question that Reed originally presented. Remember, this comes out of the notion that we need to reduce the amount of crystalloid that we're giving, right? And the idea is that we're going to increase our venous tone to improve our preload to RV and in turn improve our preload to our LV, right? In an ideal world, that's the way that it would be. But again, I've still not seen the study done in the emergency department. All of these studies are done in the ICU. All of these studies are post-acute resuscitation. So I still haven't seen the ED study where we should be doing 1 or 2 liters and starting pressors earlier that shows that we have an improved outcome. Just haven't seen it. So if once I make the commitment that the patient's going to the ICU, I think pressors start to become fair game. If I think I can get them to dodge the ICU, then I'm going to hold out a little bit longer. All right, and again, case by case, individual by individual. Frail, poor cardiac performance type patient, probably pressors earlier, probably go ahead and commit to the ICU. Younger patient who clinically looks well, I may try to push them through with fluids, all right? Because there's no proof yet that the ER resuscitation with fluids is harming the patient, just the ICU and the OR.